Hi, everybody. I'm Dr. Lisa Finkelstein, and welcome to Beyond Telehealth. And we have a wonderful guest here today. Her name is Kerry Palakanis, and she is a wealth of knowledge in regards to telemedicine, and she's very passionate about telemedicine. And as we know, telemedicine is medicine. So Kerry, I'm going to ask you first to introduce yourself. Tell us what you do, where you are potentially going to be practicing, a little bit of your history, and why you're so passionate about telemedicine.
Great. Thanks so much, Lisa, for inviting me. Yes, I have been a family nurse practitioner for over 31 years, always focusing on patients with diverse needs and underserved and underrepresented communities. I started out in the military and then ended up in rural health for the most part of my life, although I have traversed these country back and forth. But I actually became very interested in telemedicine and remote patient monitoring about 15 years ago. And that was a result of some work that I was doing back east in Maryland. And I was in a very rural, the poorest and unhealthiest county in the state of Maryland. And part of my patient catchment area included two islands in the middle of the Chesapeake Bay. They're called Smith Island and Tangier Island. And you can Google them and listen to the dialects. These two islands can only be reached by boat, with the exception Tangier has a very small runway for small aircraft. But there are no roads to get there. When the Chesapeake Bay freezes over, or when the winds are high and the waves are high, the individuals that live on those islands, it's about a total of 600 between the two islands. They have no way to receive healthcare. There's no clinics on either island. There's no healthcare providers there full-time year-round. There's a couple of folks who have some vacation homes there. But these individuals on these islands have been there since the early 1600s. They were amongst the original settlers.
Wow.
And I usually joke that they reminded me a lot of, I was born and grew up in Appalachia, that there's only 4 last names on the island, and you're one of 4. Reminded me of when I was in the Aleutian Islands, same thing. So I was really looking for a way to reach these patients when they couldn't make it across. It was a 45 or 70-minute boat ride for them to get to my clinic from the island. So I started exploring telehealth, and along that way also was looking at remote patient monitoring, because it had just became approved codes, and CMS was going to approve it. And I was working with a group of individuals that were working with responses to CMS about these codes and how we thought that they should be administered. So my first remote patient monitoring program I launched was in 2013. And in 2013, I used community health workers as the backbone of a remote patient monitoring program. And since that time, have had multiple evolutions of remote patient monitoring programs using a variety of different staff techniques.
Okay, so the topic of today is RPM, or remote patient monitoring. And a lot of us don't really know what is 101 remote patient monitoring. What does that mean in its most basic sense?
It's a great question, and it's not very complex. When you look at the CMS language in relationship to RPM, it can befuddle you, but it doesn't have to be. Remote patient monitoring is the monitoring of physiologic data. It's there are several codes, and we can go over those codes, but you're basically receiving anything that is electronically transmitted physiologic data. So it's not the patient taking their blood pressure and sending you their blood pressure. It is a physical, actual translation of that data across the internet or across telephone, or however you want to transmit it. But it's the remote monitoring of physiologic parameters. You can look at weight, blood pressure, pulse ox, respiratory rate. There's a lot of really interesting devices out now that get all different kinds of biometric data. So it's any biometric data that you're remotely monitoring and acting upon to care for our
So
patients.
let me ask you a quick question. Does it count if the patient is self-reporting, or does it have to be internet, Bluetooth enabled, transferred, into a medical record?
Super great question. The answer is the patient can self-report, but there's I think the key thing that I drive home with RPM that any provider needs to understand is that there is a minimum number of data that has to be reported to meet the billing criteria. So there's two separate codes. Well, there's actually three separate codes. There's a code for the initial setup and education of a patient. That's 99453. That code can be done by a supervised employee. If you have your nurse or your MA setting a patient up, they can do that. That's only billed one time, and that's at the start of treatment. And it's not a very high reimbursed code. It averages around $18, $19. And that's meant to cover the time it takes to educate the patient on the program and on the expectations of the program. But you can't bill that monthly. It's one time. And then the next code that comes along is 99454, which is the actual readings, the biometric readings. In order to reach the threshold for billing, you must have 16 separate daily readings over a calendar month. So actually, forgive me, that's 16 separate daily readings over a 30-day period.
30 days, right.
Yep. And so that can't be that the patient does 4 today, 4 a week from now, 4 a week. It has to be, 4 days out of the week, averaging about 4 days out of the week to get to that threshold. Right now, I feel like I'm doing an infomercial today.
Yeah.
With the public health emergency, that threshold is waived. So currently, CMS does not require the 16-day reading threshold for remote patient monitoring. But as soon as the PHE is no longer in place, that exception will go away. So it's good practice to just say, okay, I need to have 16 separate readings in a 30-day period on 16 separate dates. And then there's a second code to remote patient monitoring, which is the 99457. There's also a 458. I'll get into that in a second. That's the actual management services. And that's 20 minutes or more of a clinical staff, physician, or other qualified health provider's time in a calendar month. So you've got the biometric readings that are 16 and 30 days. And then you've got the actual clinical management, which is 20 minutes in a calendar month. Now, I don't know why they did them separate. It's crazy. Every RPM program I run off of a 30-day cycle because it's just easier for me to do it that way and monitor it.
Right.
But this with RPM, you can use delegated staff time, but you, the billing provider, are still responsible for ensuring that the work has been met in order to do that. And you must submit a note in addition to the billing that says you have reviewed and agree with the plan that's been in place, or you've reviewed the time. I have a pat sentence that I just copy paste. It's in my templates.
Yeah, the template. Okay.
Yeah. And those sentences were given to me from my billing/legal team that said, this is what you need in order to make everybody happy. But it basically says, I have reviewed the readings. I concur with the plan that's in action, and I believe the patient still will benefit from continued treatment. Or maybe I say the patient no longer requires this treatment.
Right. So, during COVID, when patients were coming in with respiratory problems, but they didn't need to be admitted, let's say, and they were sent home with this gift box of remote patient monitoring, the iPad, the pulse ox, the temperature, all that stuff. That's not going to meet the criteria for billing because it potentially they were only doing it for a couple of weeks and then they're done. And so, right. And so my question is, it's obviously confusing, but what is the best type of patient in your mind, best use case for remote patient monitoring?
Ironically, Lisa, the fact that CMS did the exception rules, that COVID patient does meet the criteria.
Oh, because of the public health emergency.
Um,
Right, right,
and
right,
so
right,
I was working at Intermountain during the height of COVID. And
right.
at that time, we ended up monitoring close to 15,000 patients that would have otherwise been hospitalized. We started out with just doing
Yeah,
patients that met the high risk criteria. And then we moved from patients that were high risk or at risk into patients who had presented to the emergency room, and the only treatment they needed was oxygen. And we would send them home with oxygen. And actually, we only gave them a pulse ox. It was a little $20 pulse ox, and then our backbone RPM program that fed into our nurse monitoring center. And there's actually two published studies that Joey Bledsoe and Harris
yay, go
Carmichael
Joe.
put in.
Yes,
Yeah,
yes.
yeah, Joey and Harris have published two studies on our outcomes with that. We have incredible outcome data associated with those
Is
studies.
that published? It's done?
Yes. Yep.
Okay.
Um, I should be professional enough to tell you where to find it, but I'll be
That's all
honest
right.
with you.
I interviewed Dr. Bledsoe, so I'll
Yeah.
give him a call back and ask him where it is.
Yeah, or I can send it to you. It's fascinating. We basically saved about 4.2 hospital days per patient, which
Wow.
translates into quite a bit of money. But I think from my standpoint, the thing that was really fascinating about that was the qualitative data that we got back. Now, I'd been doing remote patient monitoring for over 10 years. I felt like I was fairly much a competent individual with it, designed the program to try to meet a need, but had really no idea the benefit of using monitoring for an acute environmental issue. And it was fascinating. We have so many good stories from the patients. We were monitoring pregnant women with COVID. We were monitoring very high risk individuals with COVID. And really, the number one thing the patients would say is, I just felt like there was somebody always there with me.
Right. Putting
Now,
eyes on them, and if
yes.
they needed to come back to the hospital, then you would say, this isn't working, you need to come back and
Mhm.
potentially be admitted. You just mentioned something. I just had a thought popped in my head. OB patients. One
Yes.
of the things that is an unbelievable tool, and as a urologist, ultrasound has always been uh, huge in our practice. And the handheld ultrasounds, Butterfly, that the things that you can put in your
Mhm.
pocket, that is, my brain goes to, well, why couldn't you give that to a mom and have her, do a Doppler and ultrasound at home? And could that count as RPM?
It wouldn't count as RPM because it's not biometric data. If you think about it, it's more of a radiologic or ultrasonic data response.
Hmm.
But you could, you could make the argument of fetal heart tone. But remember,
Yeah.
the parameters that we're talking about are set by CMS,
Yeah.
and rarely is a pregnant woman under
Medicare.
Medicare.
Yeah.
It's almost always commercial. But that said, you're absolutely right. Right. I have a good friend who has a company called 19 Labs, 19 LABS, and they've got on their website some work that they're doing in Oaxaca, Mexico, giving fetal stress test monitors and ultrasounds to pregnant women in the rural areas of Oaxaca, and they're like 3-4 hours away from clinics. Fascinating outcomes in there because they had such high maternal morbidity and mortality. The government of Oaxaca actually hired this company to come in and try to help them solve this issue. And then we at Intermountain as I was leaving Intermountain, Sean Esplin and the team are working on a hypertension monitoring program for pregnant women at risk. The problem in the pregnant population, the maternal child population, is the reimbursement doesn't exist. And of course,
Right.
it's also a global payment system for pregnancy. So even though it's doing the right thing, the person who ends up having to pay the bill is the physician who's already receiving a reduced payment in a global
Right.
environment. But there's something to be said for, should every pregnant woman knowing that 17% of all pregnancies end up with some kind of a hypertensive response, whether it's eclampsia, preeclampsia, or HELP. There's a lot to be said that if we gave every pregnant woman a blood pressure cuff, we could reduce maternal morbidity and mortality overnight.
Right. So again, the elephant in the room here is that, you and I and the people that have been in telemedicine for a long, long time know that it works.
Yes.
And then, right, it's simple, it works. But then we have the payers who are not paying for these types of things. And, to look in a little bit of your crystal ball to say, in the future, remote patient monitoring or programs like hospital at home, do you see this type of thing as staying, paying, and going to be a part of our world permanently?
Great question. And I absolutely do believe it's a part of our world. If anything, I believe it's got a stronger sense of survival in the future than it did in the environment it grew up in, because it lends itself perfectly to value-based care models. So when you're in a value-based care model, right now, you're absolutely correct. We're relying on the insurers, the payers, to reimburse us for this service. And they have the right outside of Medicare to choose to include or not include these codes as a reimbursable service. But if we are doing the work, they're going to gladly let us reduce their risk and save them money. But in a value-based environment, remote monitoring really takes legs on and runs, because we can do exactly what you and I know we can do, which is we can look at trends and do predictive analytics and identify which patients are more likely to have significant poor outcomes. So I see a future that's a much rosier one than if you'd asked me 8 years ago when we were just a couple years into RPM, because more and more the commercial payers are looking at RPM and are reimbursing it, but they're not yet required. There are a few states that do require. Texas, actually, ironically, Texas Medicaid covers RPM and covers it quite well. And a lot of people hold Texas up as an example because they actually are. The reason why Texas Medicaid did it is they've had such great outcomes in the pediatric environment with remote monitoring.
Carrie, there's a question here from Amy Serdam, who I don't know if you know Amy. So she's on the east coast of Wyoming. Hi, Amy. And she's a nurse. I think, is Amy a nurse practitioner or PA? I forget. Anyway, she asked for 99457. There is some debate about clinical staff time. Does this need to be 20 minutes of interactive time with the patient or just include an interaction? Okay.
Great question. It has to include at least
FNP. Hi, Amy. She's an FNP.
That's why she has such a great question. No,
yeah.
It has to include at least one interactive communication. Now, that interactive communication can be text back and forth, email back and forth. Ideally, it's a live back and forth communication. It doesn't have to be between the provider and the patient, but between two individuals performing the service. And then that 20 minutes is cumulative. And there are some RPM platforms that give you a ticker that whenever you open up the platform to do the service, it runs a timer for you. I've actually done it myself with just telling my nurses to, look at the time that you start the visit and look at the time that you stop the visit. It just depends on how technical you want to get with that. And then after that 20-minute threshold is when 99458 comes in. You can do an additional 20 minutes if that patient warrants it. I would discourage somebody from applying the 99458 to every one of their patients. That's a sure way to get an audit.
A red flag, yeah.
That 58 should be for those patients with chronic conditions. I was going to tell you, I had such a great response from my COVID patients, but simultaneously during COVID, my mother has heart failure and she was placed on the monitoring system that I was managing. And I would come home every night and she would say, I hate those people at the monitoring. So they keep calling me and telling me I haven't given them my results. And I said, well, did you? And she says, no. And I said, right. They're doing their job. So don't fault them for that.
So you did say that the best case is to have it real time synchronous interaction, but it can be asynchronous.
Yeah, it can be asynchronous, but ideally what CMS wants is a synchronous, and that can be also part of the obviously that education and teaching visit, but also I can guarantee you if you are doing remote patient monitoring correctly, there's at least one time that whether it's a community health worker, MA, nurse, or the billing provider has to pick up the phone and say, you didn't send a reading, or your reading was looks like it might have been falsely elevated. Can I have you sit down, rest for 15 minutes, uncross your legs when you take your blood pressure, all of that. It's some of the calls that you get when you call in a patient all of a sudden has a respiratory rate of 32. And
right.
What the heck is this? This patient's respiratory rate's normally 18, 16. And they go, oh, I was running out back and forth and I wanted to see how high it got. Or, right. The other one that we get a lot with blood pressures is my daughter came to visit and borrowed the cuff. So a lot of the devices I use are directly Bluetooth linked in. So as the patient takes it, it will transmit the message, or it will transmit it at the next login. So I have rarely gotten to a point, and again, this is one of those built-in triggers that I do with the teams when I set them up, that we make sure that at least one of those occurs. Sometimes it occurs at the 30th day because we realize we haven't done it.
Yeah, right, great.
But most of the time there's an incident, or the patient is calling, asking because they need a refill of their medicine, fill in the blank. I've been trying to get a hold of this specialist, I can't get a hold of them. So it doesn't have to be necessarily about the biometric, but it has to be about the patient's complex issues.
I've been a big fan of RPM for many years too, but I have to say that it has been difficult because when you're trying to set up a program, it's so involved with, I call it the 7-layer cake, right? You need to have all these layers in place. And somebody like you who is willing to coordinate and get these programs off the ground, when as we were talking about, you listen to the companies talk about, okay, well, this is simple, and here's the codes, right? So this painting a picture of how wonderful it is, and it is, but it takes a lot of work to get these things off the ground, and so that I failed to get it off the ground because of that.
And you are not alone, Lisa. Lots and lots of individuals have done that. And I'm sure you can provide my email out to anybody. I'm happy to give people some just helpful advice. There are some really low cost providers out there now. You probably haven't heard of them. And I have friends in the RPM industry that go from just devices all the way up to full service. They've got the nurse and they're doing the whole cycle for you. And, they're billing everything and giving you,
$3.07.
Yeah.
Right.
So, there's a very big spectrum there. And so a lot of times when I talk to somebody about RPM, the first question I ask is, how much work do you want to do? Because if the answer is as little as possible, then they're probably going to have to look at working with a vendor that offers some services. If they want to maximize their revenue and not give away the store, then it just takes a structured program and at least one individual in your office that you can rely on to make sure you meet the check marks along the way.
Right. And let's see, what time is it? All right, we're going to do one more question and then I'm going to bring you into the future. With the last omnibus bill that passed, that they extended, one of the benefits of telehealth was the RPM, CMS paying for RPM, correct? Until the end of 2024?
Correct.
Okay. So everyone that's out there and Amy, that is doing RPM, that it's for CMS at least, not for the private payers, that we're in the clear until December 31st.
And RPM itself has been around, like I said, for about almost 10 years now. So that will stay.
It's not going away. Okay.
Yeah. I think, that omnibus response is mostly to the fact of telehealth requirements that used to require rurality. And I know a lot of your friends are already dealing with rurality, but rurality doesn't apply in RPM.
Right.
RPM can be used in patients in any environment.
Right. Okay.
All
right. So the last question.
Yes.
You have a very active cat back there.
Yeah, sorry. I didn't know if you could hear him.
That's okay. That's all right. So, Kerry, one of the things is, as I said, when I teach medical students and I talk to them about the future of digital health, telehealth, all of these things, looking into AI, AR, VR, and the metaverse. Where do you think the future of healthcare in a digital world is headed?
That is a great question, and we could spend a day on that.
Right.
But let me start with saying that I bet pretty much all of us on this meeting have Alexa or Siri somewhere in our lives. And the reason why I say that is because you're already giving data away. And data is going with your permission to Amazon Web Services or to Google. And also, if I ask each of you to go to wherever there is a television in your house and look at the television set, in all likelihood, it's a smart TV. And smart TVs can, with very minimal effort, be converted into telemedicine systems.
Right.
We do that right now in the hospitals. We add a microphone and we add a camera, and voila. I think, I'm not a soothsayer, but within the next 5 years, we're probably going to have embedded cameras and microphones in our televisions. And so everything will be ripe and ready for telehealth.
You mean in the hospital or in your house?
In our homes.
Right.
Yeah. Right. And so that the future of telehealth is sitting in your living room. It's looking at that TV and knowing that that TV can do a couple of things in the near future. First of all, it'll allow you to communicate with your healthcare provider. It might allow you to resource some healthcare ancillary services. You might be doing your hospital at home, admission, discharge, and care all through the TV in your living room. You can do your remote patient monitoring, because with computer vision learning, we can passively ingest a lot of the data that we're currently doing with devices. And then where AI and machine learning come along is taking that data and creating the trends that do a predictive analytic formula, which we are doing right now with just the Bluetooth enabled. So we're really on the forefront of having real-time ingestion of our biometric data from our home environment and having that go transmitted somewhere. And I emphasize somewhere, because you're either going to be part of it or you're going to be a participant in it. Right. So I think, we have to think about
the
that.
Providers and the students, the medical students that are heading into that world, what I say to them is, don't be afraid, because even the medical students have anxiety over the metaverse and what this looks like. And, the virtual world to them is it's interesting to me that they're nervous about it. And I say, don't be afraid of it, because it would be great if you told Mr. Zuckerberg how the metaverse in healthcare is going to look like, not let Mark Zuckerberg tell you.
Right, because we don't want it designed like an RPG game. We want it designed to be able to maximize our ability to translate that data into outcomes.
Right. Okay, we are pretty much there. We could talk for days and days, Kerry. You have so much knowledge and experience with digital health, and I'm so glad that we met when you were at Intermountain. It was just a great find. Stay on right now, but I'm going to end the broadcast, okay? All right, I'll see you in a sec. Thank you.